Hello, my name is Gabriela Cueva and I'm going to talk about Pembrolizumab for the treatment of non-small cell lung cancer. Definition: about 85% to 90% of lung cancers are non-small cell lung cancer, NSCLC. It usually grows and spreads more slowly than small cell lung cancer. There are three main subtypes of NSCLC: squamous cell carcinoma, found in the center of the lung next to the bronchus; adenocarcinoma, found in an outer area of the lung; and large cell carcinoma, found in any part of the lung. They tend to grow and spread more faster than the other two types.
The pathophysiology of non-small cell lung cancer. Lung cancer is the leading cause of cancer-related deaths in the Western world. Non-small cell lung cancer, or NSCLC, accounts for approximately 85% of all lung cancers and is divided into three subtypes: adenocarcinoma, or AC, squamous cell carcinoma, or SCC, and large cell carcinoma. The different types of NSCLC develop in different locations of the lungs. Adenocarcinomas develop in the peripheral portions of the lungs in alveolar type 2 cells. Squamous cell carcinomas develop near the center of the lungs in mucociliary epithelial cells, and large cell carcinomas may occur in either location with squamous and glandular features. Risk factors associated with NSCLC include smoking, secondhand smoke, occupational carcinogens, and diet, nutrition. Smoking remains the leading and most preventable cause of lung cancer, accounting for 80 to 90% of cases. According to current views on the carcinogenesis of NSCLC, the transformation of a normal lung cell to malignant carcinoma requires the accumulation of multiple genetic and epigenetic alterations. It is believed that early alterations are caused from point mutations or chromosomal deletions that inactivate tumor suppressor genes, or TSGs. A TSG loss that is thought to occur in 80% of NSCLC cases is that of P53. P53 is a transcription factor for various downstream targets that are involved in cell progression, DNA repair, and regulation of apoptosis. Mutations to P53 hinder its normal tumor-suppressing capabilities. Thus, DNA damage remains unchecked, faulty cells proceed through the cell cycle, and apoptosis is evaded. This creates a genetic condition in which the cell is more susceptible to further mutations. Another critical alteration that occurs in the development of NSCLC is the activation of oncogenes. In 50 to 90% of NSCLC cases, the epithelial growth factor receptor, or EGFR oncogene, is upregulated. The binding of EGF activates signaling cascades that modulate the transcription of genes important in cell proliferation and resistance to apoptosis. In the majority of lung cancers, the activation of telomerase, a telomere lengthening enzyme, is detected. Telomeres are hexameric nucleotide repeats that protect the ends of chromosomes from unraveling, analogous to shoelace tips. Telomeres shorten with each cell division, limiting cell proliferation. By extending the telomere, telomerase contributes to prolonged cell survival. In order for pre-malignant cells to progress towards malignancy, cells must be able to escape programmed cell death. Additionally, in order to sustain growth and metastasize, tumor cells require an adequate blood supply and consequently promote angiogenesis. Tumor cells promote angiogenesis by producing vascular endothelial growth factor, or VEGF. VEGF binds to VEGF receptors on endothelial cells, inducing the formation of new blood vessels from pre-existing vasculature. This vasculature sustains tumor growth. The accumulation of these and other genetic and epigenetic alterations may randomly occur throughout the genome and eventually lead to NSCLC. As NSCLC advances, the tumor may spread to other areas of the lung and to other organs.
Causes: smoking, cotton exposure or high levels of air pollution, working with chemicals such as uranium, nickel chromates, coal product, mustard gas, gasoline, pigments, and etc. Stages of NSCLC. Stage 0. The cancer is found only in the top layers of cells. It has not invaded deeper into lung tissues. Stage 1A. It is no longer than 3 cm across. Has not reached the pleura. Stage 1B. It is larger than 3 cm across and has grown into the main bronchus. It has grown into the visual pleura. Stage 2A. It has no longer than 3 cm across. Does not affect the main bronchus of the bronchi, and it has spread to the lymph node. Stage 2B. It is larger than 5 cm across. Stage 3A, it can be any size. It has not grown into the mediastinum, the heart, the large blood vessels near the heart, the trachea, esophagus, the backbone, or the cardiac. Stage 3B, it has grown into the mediastinum, the heart, the large blood vessels near the heart, the trachea, esophagus, the backbone, or the cardiac. Stage 4, the cancer has spread to the other lung. Cancer cells are found in the fluid around the lung, malignant pleural effusion, and around the heart, malignant pericardial effusion.
So the Eastern Cooperative Oncology Group is one of the 4 adult cooperative groups that are involved in conducting trials for patients with cancer. And I'm happy to say that the Thoracic Committee at ECOG is in the forefront of developing targeted treatments for patients with molecular targets, treatment options for patients who do not have a fully defined molecular target at this point. We're invested in understanding and improving treatment options for patients with every stage of lung cancer, small cell, non-small cell lung cancer. Now, if you move to stage 3 lung cancer, there's a lot of controversy on what's the best way to take care of patients with stage 3 lung cancer. Should they have surgery? Should they have chemotherapy followed by operation? Should they have chemotherapy and radiation and not have surgery, or should they have both? So this has been an ongoing controversy for a long time. One study that we have in development is to use PET scan to identify which are those patients who might need more aggressive treatment or who may be just fine with what you're doing. So this study will basically get a PET scan for patients with stage 3, and they will start chemotherapy. And as soon as they get the first treatment, in 3 weeks, we'll get another PET scan. And we're going to see if that change in glucose uptake in the tumor and the lymph nodes can tell you which patient is going to be just fine with continuing the same chemo and who is not. So if you find out somebody is not going to do well, then you can change plans and adapt to that information and go with the more aggressive approach, perhaps adding chemo and radiation to see if that would be a better way to improve cure for those patients. So that's a study that we are in the developmental phase. We plan to have it available in the next few months.
Application in medicine. Pembrolizumab, Keytruda are drugs that target the PD-1, a protein on immune system cells called T cells. The numeric help keeps these cells from attacking other cells in the body. By blocking the PD-1, these drugs boost the immune response against cancer cells. This can shrink some tumors or slow their growth. These drugs can be used in people whose cancer starts growing again after chemotherapy or other drug treatments. These drugs are given as an intravenous infusion every 2 or 3 weeks.
So this is really an exciting clinical trial that we're embarking on. There have been some really interesting discoveries in lung cancer recently, and probably the most important is this discovery of the interplay between the immune system and cancer. One of the mechanisms by which cancer cells resist kill by the immune system is that they have expression on their surface, something called PD-L1. And And that PD-L1 interacts with something on the immune cell called PD-1. And that interaction between those two proteins prevents the immune cell from attacking the cancer cell. There are now a new class of inhibitors called PD-1 inhibitors. And basically, this class of drugs disassembles that interaction between the immune cell and the cancer cell. The PD-1 inhibitors by themselves are not cytotoxic. They by themselves do not kill cancer, to the best of our knowledge. What they do is they disarm that interaction to allow the immune cell to kill the cancer cell. Now that sounds wonderful, but does it really work? It turns out it really works. This class of PD-1 inhibitors has been broadly active against a number of cancers, including heavily pretreated advanced non-small cell lung cancer. One of these drugs in particular, called Pembrolizumab, which is an antibody against PD-1, is a drug that we are particularly interested in studying. This drug is highly active in chemotherapy refractory disease in patients with advanced disease. And what's really exciting is that there are a subset of patients who not only respond, but respond for very long periods of time, much longer than what we see with typical chemotherapy. Now that's great for patients who are suffering with advanced disease. Perhaps they can get a reprieve. But what we really aim to do in the management of people with cancer is to try to cure more patients. Well, treating patients in the locally advanced setting still is an opportunity to cure patients. And so our hope is, after completing chemotherapy and radiation therapy, that the addition of pembrolizumab will help cure more patients. The good news is for this clinical trial for patients is that they can and will receive the standard of care treatment for stage 3 disease through their local doctors. They will receive the commonly used chemotherapy regimens, either cisplatin and etoposide, or weekly carboplatin and paclitaxel, given concurrently with radiation therapy. It is not necessary for them to travel to a site that has the study open to receive all of that therapy. What we ask is for you to consider, for those sites to consider partnering with us and letting their patients know that there may be an opportunity for them to receive what I think we can all agree upon is a very promising investigational drug. This would be given approximately 1 to 2 months after they have finished their treatment at their home.
Maldita desgracia.
With their home physician. At that point, as long as the patients do not have disease growth and they remain fit and well and meet the eligibility criteria for this type of therapy, they would then be entered onto the clinical trial where they would receive pembrolizumab by IV every 3 weeks. It would require them to travel to a study site, but we are doing our very best to ensure that those study sites are within a reasonable proximity for the patient. Once the treatment is completed, they of course return to their physicians who they've entrusted with their care, and they would continue to be followed up. And certainly any further therapy that would be required for the patient would be done by their local doctors.
Pros and cons. Pros. Tumor shrunk in 41% of patients. The effect lasted between 2.1 and 9.1 months. Cons. It can include fatigue, cough, nausea, itching, skin rash, decreased appetite, constipation, joint pain, and diarrhea. It also has the potential to cause severe side effects that result from the immune system effect of Keytruda. It may cause harm to a developing fetus or newborn baby.
we've been exploring Pembro in non-small cell lung cancer, both in first line and previously treated lung cancer patient, and using a selection strategy for PD-L1 positivity. And we found that certainly using PD-L1 selection does improve our activity with Pembro. We've seen good activity in PD-L1 positive patients, both in first line as well as pre-treated lung cancer patients. So both in first line and pre-treated patients with Pembro or MK-3475, very favorable toxicity profile, very low significant AE rate, some mild fatigue, pruritus, but overall really a very tolerable drug.
Issue applied in Ecuador. The World Health Organization indicates that lung cancer represents the main cause of death in many developing countries. In Ecuador, according to the National Cancer Registry, the lung cancer is the fourth cause of death among malignant tumors, followed by gastric, pancreatic, and breast cancer. Moreover, 3 provinces represent the highest percentage of the disease: Guayas with 32.8%, Pichincha with 20.7%, and Manabí with 7.5%. It is estimated that this tendency will increase in the next years and will place this disease as the principal cause of death by neoplasias.
Non-small cell lung cancer is currently the single biggest killer from cancer of any disease in the world. It's a disease that is caused by a number of different things, predominantly smoking but not exclusively smoking. It's a cancer which arises in the lungs, although it can spread to other parts of the body. But it's always called lung cancer because that's where it starts. It's called non-small cell lung cancer to distinguish it from another rarer type of lung cancer called small cell, which behaves very differently and is treated very differently. So nobody knows the exact answer to that question, why lung cancer is so common as it is today. One argument is that because it is mostly driven by smoking, that changes in how people have smoked over time increase the incidence of lung cancer. For example, in men, the routine issuing of cigarettes during the World Wars got an entire generation addicted to smoking. And we can see a major peak in the incidence of lung cancer in men that occurs several years after the First and Second World War. In women, for example, where smoking was much less fashionable until the 1960s, the rise in incidence in lung cancer didn't peak until the 70s or 80s. So one question is, if we stop people smoking with anti-smoking policies, will we reduce the number of people who develop lung cancer? And the answer is probably. However, it's going to take many, many years. If you stop the entire world smoking today, they will still develop lung cancer over the next 10 or even maybe 20 years, because that's the incubation period for the disease. I think for most people who have experienced chemotherapy, they would argue 2 things. First of all, even in those in whom it is successful, it's not pleasant, so it would be nice to have something that worked as well but was easier and nicer to take. And the second thing is it's not a cure. Even though I say it prolongs the time that you may be living, it's not a dramatic difference, at least when you look at everybody together. So we definitely need to add to the chemotherapy, or in some people find an alternative to the chemotherapy, to not treat everybody the same. One of the key things about lung cancer that has evolved over the last 5 years is the recognition that it is not one disease. It's multiple different diseases down at the molecular level. This means that for some people, if you can find exactly what is driving their cancer, and you can block it like a key in a lock, you can turn their cancer off. Now that may not be a cure, but you can get much better control for much longer with much less in the way of side effects. And that's where targeted therapy comes in. Not just the promise of one miracle drug for everybody, but finding the exact right drug for certain groups of somebodies. My hope for the future is that lung cancer, at least in my lifetime, is probably not going to be cured. However, it will become a chronic disease. It will turn into something like asthma or diabetes, that people say, I have lung cancer, but I'm living with the lung cancer.